Good evening, everyone. Thank you for joining us this evening. We will go ahead and get started. Welcome to the Mental Health in the Black Community webinar, Taboo to Truth. And we are the Bluff City Medical Society. So we'd like to thank you all for joining us this evening. This certainly will be an exciting time. I think there is a lot of information to be presented and surely a lot of knowledge between all of our panelists. So just some brief housekeeping. We are live streaming this event on the Bluff City Medical Society Facebook page, and we are recording this webinar so that it will be posted to the Bluff City Medical Society YouTube page after the event. I will say take a moment to like, share, and start a watch party to bring more people into this conversation. If you're looking for us on Facebook or any social media, including Instagram and Twitter, we are at Bluff City Med. If you have any questions, please enter them into the question and answer feature and any comments into the chat feature, and we will get to as many as possible. However, I will say that we got a ton of questions during the registration for this event, but a lot of them were redundant, but we'll make every effort to get to as many questions as we can. And then I did get a lot of questions about CME being offered for this event, and unfortunately, we don't have CME that's offered for this event. So I am Dr. LaTonya Washington. I am the president of the Bluff City Medical Society. I'm board certified in internal medicine and pediatrics, and I currently work at St. Francis Hospital in the role of physician advisor. I do want to take this opportunity to recognize our community partners. We certainly appreciate them. They were happy to sign on with us for this event and share it with their networks so that we could broaden our reach. So the Memphis Association of Black Journalists, the Memphis chapter of the National Pharmaceutical Association, the Epsilon Pi chapter of Omega Psi Phi Fraternity Incorporated, the Alpha Alpha Gamma Omega chapter of Alpha Kappa Alpha Sorority Incorporated, and the Alpha Delta Lambda chapter of Alpha Phi Alpha Fraternity Incorporated, the National Panhellenic Council of the Memphis metro area, and the Memphis chapter of the Links Incorporated. So thank you to all of our community partners. And we also have our medical community partners. These individuals are always supportive of the events that we have at the Bluff City Medical Society, Baptist Hospital, Regional One Healthcare, Church Health Center, Methodist Le Bonheur Healthcare, and St. Francis Hospital, Memphis. So thank you to all of our community partners and our medical community partners as well. I would like to give you all just a brief overview of the Bluff City Medical Society. Again, we have an overview video that is offered on our website, so I am going to attempt to share that with you guys. So hopefully you will be able to hear the audio. Welcome to the Bluff City Medical Society, the premier organization for physicians of color in the Memphis metropolitan area. Our vision is to establish and maintain physician best practices, to eradicate healthcare disparities, and to provide mentorship and education for medical students, residents, and fellows. Our founder, Dr. Miles Vanderhurst Link, was the first president of the Bluff City Medical Society. He also established the first medical journal for Black physicians, the Medical and Surgical Observer, and founded the University of West Tennessee to educate Black students in medicine, dentistry, and law. Dr. Clara Bronner was the first Black woman physician practicing in the Memphis area. She was also the first female president of the Bluff City Medical Society and a leader within the Memphis community. Dr. Edward Reed was a pioneer and former chairman of the board at the Regional Medical Center. He was also the first Black president of the local American Cancer Society chapter. Dr. Robert J. Smith was a general surgeon and really served as the gateway to introducing multiple medical students to surgical techniques. Dr. Beverly Williams Cleaves is an associate professor of medicine and endocrinology and the University of Tennessee College of Medicine graduate. She championed community health fairs and educational outreach in the Memphis area. As you can see, the Bluff City Medical Society is really committed to our community. Our annual Robert J. Smith Scholarship Gala and Lecture is one of the highlights where we provide scholarships to medical students. We conduct the Bluff City Medical Society Business of Medicine Symposium to remain up to date on pertinent business of medicine topics. We conduct our Healthy Eating and Living initiative to provide healthy ways of eating as well as health screenings to our community. Many members are very active with political activism as well as social justice initiatives, including the White Coats for Black Lives event. We are committed to enhancing the experiences of underrepresented minority students who desire to pursue medicine as a career. Please visit our website at www.bluffcitymedicalsociety.org. Also follow us on social media. We're available on Facebook, Instagram, and Twitter at Bluff City Med. Thank you. So that was just a brief overview and highlight of the Bluff City Medical Society. Again, please take an opportunity to check out our website for additional information. So we will go ahead and get this program started. Again, we do have a lot to cover. We will start off with a mental health 101. This event is, this mental health topic is going to be covered by our residents and fellows in psychiatry. I will have them introduce themselves as well as give the year of training that they're in. And so ladies, you can take it away with for Mental Health 101.
Good evening, everyone. I'm Dr. Mallory Mitchell, and I am a fourth-year fellow training in child and adolescent psychiatry at the University of Tennessee. And I'll let Dr. Ford introduce herself as well.
I'm Allison Ford. I'm a PGY5, graduating in June at UT.
All right. And so before we hear from our very esteemed panelists here in a few minutes, Allison and I are just going to do a general mental health overview and answer a couple of the very great questions that came up as part of the registration process in terms of like, what is mental health? What are the different types of mental health providers? And for our clinicians, how do we go about effectively referring our patients for mental health evaluation and treatment?
Dr. Mallory, I think you're muted.
I'm sorry about that. Okay. And so the CDC defines our mental health as our emotional, psychological, and social well-being. And so this impacts us not only internally in terms of our thoughts and our feelings and our behaviors, but also externally, and determines like how we cope and respond to stress and how we relate to others in terms of like our family and our friends and our coworkers, and then how we make healthy choices in other aspects of our lives. And so it's important to note that mental health is for everyone at each stage of our life, from childhood and on into adulthood. And this is a quote that I came across that I really like to use when emphasizing the importance of mental health for all of us. And it says, remember, if you're not speaking on things, then effectively you're storing them. And it doesn't matter how strong or how resilient or how tough we are, eventually those things are going to get really heavy. So we all need that sort of outlet and that safe space to talk about the difficult things and the experiences and everything that's going on in our lives, whether that be informally or formally. And so say you want to take those next steps in pursuing some formal mental health support, either for yourself or for your family members or for your patients. Sometimes that can be really overwhelming when thinking about like, how do I get started with that? And that's where some knowledge of the differences in providers might be beneficial. So like, what really is the difference between a psychiatrist and a psychologist and a therapist? And effectively, all of these providers are experts in, mental health evaluation and diagnosis and treatment. And in terms of treatment modalities, all of these providers can do psychotherapy, but when we think about more specialized types of psychotherapy, for example, maybe trauma therapy or play therapy for small kids, sometimes our psychologists or our therapists will be our experts at that. And there are some additional differences. For example, medical psychiatrists are actually trained as medical doctors. So they go to medical school and they have an internship where they receive some general medicine training before moving on to specialize in psychiatry. And that's important in how they view mental health, often from a biological perspective as well, and considering the things that go on inside of our body that affect our minds and vice versa. And then psychologists and therapists also often have advanced degrees in things or things like a PhD or a doctorate in psychology or master's level training in social work or professional counseling that provides them with expertise in clinical practice and then also in research too. And as a general rule, when we think about prescribing medications, we'll think about a psychiatrist. However, there are exceptions to that rule, and nurse practitioners that specialize in mental health can prescribe medications independently or with supervision from a doctor. And then in limited states, I think there are about 5 right now. So Louisiana, New Mexico, Illinois, Idaho, and Iowa, with additional training, psychologists there can also provide medications. And another area of expertise for psychologists specifically is that of psychological testing. So if you think about things like academic testing or aptitude testing or neurocognitive testing, a psychologist might be your go-to. So overall, when thinking about how do I choose a provider to start with, it'll really depend on individual needs of yourself or your patients or your family. So if you have someone that's experiencing a complex mental health issue that's really impacting their day-to-day functioning and something that might require medication, for example, like very severe depression or bipolar disorder or schizophrenia, it might be a great idea to start with a psychiatrist for an initial visit. But alternatively, if you have someone that maybe is having some milder symptoms, like a mild depression or a mild anxiety, or situationally going through a hard time, or even somebody who's overall well, but just really wants to, better understand how they're thinking and behaving and improve their overall life, then a therapist might be your go-to. And that can be done as an individual or couples or family therapy or group therapy. And there's no really wrong place to start in terms of seeking professional support, because that's why we're here to help guide everyone through that process and doing a thorough kind of evaluation and coming up with a plan for how best to approach each individual's concerns. And so now I will turn it over to Dr. Ford.
Thank you, Dr. Mitchell. So our esteemed panelists will talk a little bit more about barriers to mental health treatment, but we wanted to touch on just barriers to a successful referral and how we can, as psychiatrists, can help mediate that avenue into mental health treatment. So one of the barriers is just differences in training. A lot of primary care providers are trained in hospitals or community programs that don't have access to a psychiatry residency. So it may be unclear what we do in a hospital setting. The MD-patient relationship, so say this is a new patient or someone that you haven't had time to build true rapport with, they're going to be a little bit apprehensive when you say, okay, well, we're going to refer you to a mental health professional. Unidentified psychosocial problems. So it's hard to pick up, marital problems or trouble with a sick parent in a 15-minute follow-up visit in an outpatient PCP practice. A big issue now is technology. So a lot of mental health professionals are going to telemedicine, but especially in Memphis, a lot of people don't have access to Wi-Fi or iPhones. I still have plenty of patients still using a flip phone in 2021. Patient fears and apprehension. So again, patients not exactly knowing what a psychiatrist does. All they have, the only ideas they have of psychiatry are what they see on TV and movies, and that may not always be the best portrayal. And then patients feeling that the MD is implying that, quote, it's all in my head, right? So having trouble understanding how stress could influence, their abdominal pain, their chest pain, and feeling that the PCP is implying that what they're feeling isn't real. So how can I help? I can help foster relationships with my non-psychiatrist friends, continuing to advocate and explain what I do. I can recognize the burden of PCPs and have some sympathy that it's hard to understand everything that's going on with the patient when you have to see 20, 30, 40 people in a day. Helping to reassure the patient that the primary care provider isn't abandoning them, that really I'm working in collaboration with your OB or your internal medicine doctor. And continuing to provide direct feedback to the primary care doctor. I know if some of you have seen psychiatry notes that read like novels. And so being more direct in my plan of care, and again, continuing to be more collaborative in our treatment of patients. So you sent the referral and the patient says, yes, I will go see the psychiatrist. So one way to prepare them is to explain that it may take several visits. So unlike the GI doctor where you can go and get a scope and get a good sense of what's happening, it may take a psychiatrist 2-3 visits to truly complete a diagnostic evaluation. And so this is a blurb that I like to use on the consult service where I try to explain to people why they should come see me in an outpatient setting. So I would say, I think your symptoms may be related to the stresses in your life that have been discussed. They can cause changes in metabolism or physiology, even pain. Just as I'm not a specialist in cardiology or urology, I'm also not a specialist in the many ways stress affects our body. And I would like you to see someone who does specialize in the field to see whether there are things we can do together to help get you some relief. And so after you've seen Dr. Ford, I will continue to see you and to implement these suggestions. So these are our resources, and thank you for your attention, and we'll throw it back to Dr. Washington.
Thank you, Dr. Mitchell and Dr. Ford, for that great overview. So that's Mental Health 101. We got a lot of questions about that initially. I felt like that would be a good overview for us to start. And then now we will get into our discussion. We have some other residents who are going to come in and they will be introducing our panelists for the evening. So first we will have the introduction of Dr. Stewart.
Good evening, everyone. I am student Dr. Caitlin Butler, a rising PGY1 psychiatry resident at the University of Tennessee Health Science Center at Memphis. Today, I have the honor of introducing our next speaker, who is a strong and powerful trailblazer in the medical community. She exemplifies what it means to break barriers, to walk the roads untraveled. She has led the way in destigmatizing mental health through her work. Her passion is unquestionable, her dedication undeniable. Currently serving as the Senior Associate Dean for Community Health Engagement and Director of the Center for Health and Justice Involved Youth at the University of Tennessee, Memphis. She completed her medical degree at Temple University, located in Philadelphia, in her psychiatry residency at Hahnemann Medical College and Hospital, formerly known today as Drexel University, where she served as chief resident. She is the recipient of many awards and honors, including, but not limited to, the 2002 NAMI Exemplary Psychiatrist Award, 2006 American Psychiatric Association Alexandra Simmons Award. In 2006, she received from Regis College an honorary Doctor of Laws degree. She's an honorary member of the South African Society of Psychiatrists, and she was also an invited participant at the 1999 White House Conference on Mental Health. In 2013, she's named the Black Psychiatrist of America Distinguished Dr. Andrea Delgado Memorial Lecturer, and later received their Lifetime Achievement Award at the 38th Annual Transcultural Psychiatry Conference in India in 2017. And this is just to name a few. Our speaker is active in several professional organizations and has served as president of both the Association of Women Psychiatrists and Black Psychiatrists of America. Perhaps one of her most notable accomplishments to date is being elected the 145th president of the American Psychiatric Association, and was groundbreaking, being the first African-American ever elected to this position in the 175-year history of the organization. A Memphis native like myself, I am proud and honored to introduce to some and present to others, Dr. Altha J. Stewart.
Thank you. Next, we will have the introduction of Dr. Patrice Harris.
All right, good evening, everyone. My name is Dr. Edna Chikunguo, a current PGY2 at the University of Tennessee Health Sciences Center. I have the awesome pleasure of introducing Dr. Patrice Harris this evening. Dr. Harris was the 174th president of the American Medical Association and the first African-American woman elected to the position. She served from 2019 to 2020. Dr. Patrice Harris was born and raised in Bluefield, West Virginia. She completed her Bachelor of Arts in Psychology, Master of Arts in Counseling Psychology, and Doctor of Medicine, all at West Virginia University. She went on to complete a general psychiatry residency, child and adolescent fellowship, and forensic fellowship at Emory University. While at Emory, she served as a Barton Senior Policy Fellow under the School of Law, where she was an advocate and addressed public policy for abused and neglected children. She continued her work in public policy and psychiatry as the founding president of the Georgia Psychiatry Political Action Committee. Starting in 2003, she has had multiple leadership positions in the American Medical Association, including serving on the Council on Legislation and the Board of Trustees, both as a member and chair. She also served in the Women Physicians Congress, as well as multiple task forces covering health information technology, payment and delivery reform, and private contracting. Outside of the American Medical Association, Dr. Harris has continued to be a leader and influencer in the Black mental health community through her membership with the American Psychiatric Association, the Medical Association of Georgia, and the Georgia Psychiatric Physicians Association as a past president for that organization. She has also served as a director of health services for Fulton County in Georgia, as well as the county's chief health officer. Dr. Harris has received multiple accolades, including Psychiatrist of the Year by the Georgia Psychiatric Association and as an inductee to the West Virginia University Academy of Distinguished Alumni. Dr. Harris's expertise had been featured on CNN, MSNBC, NBC, NPR, Wall Street Journal, Huffington Post, and New York Times, Frontline Medical News, just to name a few. Currently, Dr. Harris is a private psychiatrist and consultant for both public and private organizations on improvement of health service delivery and emerging trends in practice and health policy. She is adjunct professor in the Emory Department of Psychiatry and Behavioral Sciences. She's also a visiting professor of psychiatry at Columbia University College of Physicians and Surgeons, as well as a medical editor-in-chief for everydayhealth.com. The two themes that govern Dr. Harris's professional life are passion to improve the lives of children and service to others. She's a huge sports fan and supports the Atlanta Falcons and her home school, the West Virginia Mountaineers. Dr. Patrice Harris, welcome. And we all look forward to learning from you this evening.
Thank you. Now we will transition into the introduction for Dr. Bailey.
Good evening, everyone. I am LaTonya Washington. I'm currently a third-year resident in my psychiatry training at the University of Tennessee Health Science Center in Memphis, Tennessee. And I have the honor to introduce Dr. Rahn Bailey, who is a distinguished fellow of the American Psychiatric Association and a selected member of the American College of Psychiatrists. He serves as Assistant Clinical Education at Charles R. Drew University and Chief Medical Officer of Kedron Health Systems. Dr. Bailey's career has focused on treating the chronically mentally ill, forensic violence assessments, and health disparities. Dr. Bailey received his medical degree from the University of Texas Medical Branch at Galveston. While in medical school, he received the Resident Research Award by the National Medical Association for his work on non-A, non-B hepatitis in 1988. He completed his residency training in psychiatry at the University of Texas at Houston. While in residency, he held the title of Chief Resident. In 1995, he completed a fellowship in forensic psychiatry at Yale University. He has held a multitude of leadership roles, both academically and professionally. Early in his career, he served as unit director of a schizophrenia research treatment unit at Louisiana State University in New Orleans. Shortly thereafter, while at the University of Texas in Houston, he received the Outstanding Faculty of the Year Award in 2000. Due to his volunteer work for caring for many evacuees of Hurricane Katrina in the Houston Astrodome, he was named the Physician of the Year by the National Medical Association in 2006. He has served as the 113th president of the National Medical Association. As president, he spearheaded 3 trips to the African nation of Liberia. He is currently the chairman of the board of the National Medical Association Cobb Research Institute. From 2008 to 2014, he served as a director of Elam Mental Health Center in Nashville, Tennessee, and chairman of the psychiatry department at Meharry Medical College. While in North Carolina, Dr. Bailey was chairman of the Department of Psychiatry at Wake Forest University School of Medicine and executive director of the Behavioral Health Service Line in 2015 until 2018. He is a member of the American Psychiatric Association Board of Trustees. Throughout his career, Dr. Bailey has worked with underserved and minority populations. This is evident in his work with community programs with endangered populations throughout the United States and abroad. He has 54 publications that address healthcare disparities, including two books, a doctor's prescription for healthcare reform and At Gunpoint. For his extensive work in addressing healthcare disparities, he has been funded by the National Institutes of Health, Substance Abuse and Mental Health Services Administration, Area Health Education Centers, Robert Wood Johnson Foundation, and the Snyder Foundation. In 2011, he served as the chair of Commission to End Health Disparities. He actively works to ensure that individuals in the forensic setting are adequately assessed, treated, and advocated. Thank you so much.
Thank you all. So as you can see, we have some excellence in medicine in general, but most certainly in psychiatry here with us this evening. So we are going to dive in again to try to get through many of these questions that we received and to talk a lot about some resources that are available in this area as well as nationally surrounding mental health, as well as to talk a little bit about the stigma that is associated with mental health in the Black community. So let us dive right in. I'm gonna change our view over to the gallery view so that we can bring everyone on the screen. All right. Hello. So let's get started. So let us talk about the stigma associated with mental health in communities of color. You know, talk a little bit about that, the reason for the stigma, and a little bit of the history of mental health in the Black community. I don't know how to choose who gets to start. Just dive right in.
Well, I'm always happy to lead this group because if you come behind these two, there's not a lot left to say. So I think we began understanding some of the issues around stigma when we began looking at the history of psychiatry, especially, but generally of mental health services in the United States. We began as a nation where the understanding of where Black people fit in the social hierarchy was clearly at the very bottom. And that included whether it was the general health care or their mental health care. Some of the early psychiatric hospitals that treated people who were enslaved actually were not segregated as you might have believed. The first one that was established actually in the 1700s was at not a segregated facility, but after the Civil War, things changed. Psychiatry as a field has been plagued with misinformation, misunderstanding, the same kinds of horrible experimentation on individuals going back to the time of slavery that the rest of medicine has experienced. And I think one of the big differences, as I believe, that makes psychiatry a little different perhaps, has to do with the fact that we as medical specialists work with people who are already on the edge in many ways. I mean, we're asking people to talk to us about their deep, dark secrets or their innermost feelings and concerns and private things that they don't talk about with others. And while the three of us here on this screen look like many of the Black patients who seek treatment, for many people, Black people in this country, they don't get to see us when they go for treatment. There simply aren't enough of us. And so when you add up the issues around racism, the history of the experimentation and the tragedies that happened across medicine that were not, that psychiatry was not exempt from, and you look at many of the kinds of treatments that are provided that really are not as culturally competent as they should be to address some of the unique and specific cultural needs of a people who have lived for generations under an oppressive societal hierarchy. It is no wonder that there is great concern. There is, in the more recent history, evidence that if you are Black and mentally ill, you get a different diagnosis, a much more severe diagnosis. You don't get treated with the first medicines that we know come with fewer side effects. You can be hospitalized psychiatrically if you are too active in your engagement with society. Current social justice movement included. And there's just a host of other things that contribute to this. And then there are, in fact, today present kinds of experiences that people have had with the mental health system that have left them not feeling warm and fuzzy, to say the least, about how mental health treats Black people who come for treatment. So I'll stop there and let my colleagues join in.
And I'll just add a couple things. Certainly, it's certainly hard to follow Dr. Stewart. Let me just say, though, that sometimes today, of course, during COVID, we are working a lot and doing all that we can in our professional roles, but also in our personal lives. And sometimes we forget to stop and appreciate the moment. And I would like to say that this is a moment tonight with the three of us on this panel. And so I was just soaking it in for a minute, just appreciating this moment and appreciating this conversation. And like Dr. Stewart said, certainly history matters, how Black people have been treated in medicine in general and in the specialty of psychiatry matters. There are also issues around the reasons, misunderstood and not accurate facts of reasons of why people have mental disorders. I have heard from community members that, well, I think you must be possessed by a demon, and then the whole issue around religion, and that if you have a mental illness, it is seen as a moral failure or a character flaw, or you just didn't pray hard enough. And also, I think if you look at how we have even treated mental health in the medical profession, I've heard colleagues sort of whisper, and it's sort of the last resort. I've done all I can. Maybe you need to see a psychiatrist. And so that is not integrating mental health and psychiatry into overall health. And so people feel there may be, they're different, or, it's all in my head, as you heard, by the way, wonderful presentation by the residents. And so I think that it's a lot of misinformation and disinformation out there. Social media doesn't help. And I'll add one more thing and then turn it over to Dr. Bailey. There's a lot of influence today, pop culture, media. And if you look really over the last several decades, I would say, either the psychiatrist was a murderer, right? Or, movies, I'm talking about movies, not in real life. The psychiatry was portrayed as a murderer, or actually often doing unethical things. And then you have even seen in One Flew Over the Cuckoo's Nest, electroconvulsive therapy. So there's a lot of media influences that unfortunately have portrayed those who have a mental illness in a very negative, stereotypical, inaccurate way, and also psychiatrists in that same way. So for those reasons, in addition to what Dr. Stewart said, we are where we are today with a lot of stigma around mental health.
Yeah, and I'll jump in. I think that all points being said, first of all, that the introductions by the residents were just outstanding. I think I put in the chat, I think our future is bright, as we all appreciate what we have an opportunity to really be around outstanding young people. And I'm just so pleased that I actually chose our field. I think it's a remarkable field. I've been in it 30 years and often tell persons that I'd go into it again for I think the joy it's given me and take care of patients who I think tremendously need, I think, our support. I mentioned a couple things. I think Altha's point is right. It's always tough to come behind because there's so many good points to be made. But one issue I was interested to find out tonight, we've done 3 or 4 of these this year. I didn't know Patrice had done a forensic fellowship. So I recognize we have a lot of forensic people here. Altha speaks with a great forensic background as well. But I've been in forensics for 30 years, 25, excuse me. And I remain, unfortunately distraught very often of the mistreatment of African-American persons and ethnic minority persons very often by our criminal justice system and our legal system across the board. And disproportionately, I think the younger and the more male and more African-American you are, the more the rules are made unfairly against you. And very often, I think the way in the healthcare arena, we manage you, how we write a forensic report and what decisions we make along that go. And I think that the discussion about mental health and what does it mean in the African community is so striking to me, because these seems to be government-backed and supported concerns that are not handled correctly. And organizations like ours have, I think, a role to play and an active voice that we should, I think, extemporaneously use to really speak against them. So we'll talk more about that, I think, tonight, but I think that the forensic issues remain very prominent in my mind. And one thing that I kind of drilled down over this recent year, which has been tumultuous for all of us, is the issue of pain, really emotional pain and physical pain. I think it goes without saying that the image, real and perceived, of George Floyd kind of comes to all of our attention. But I think we do live in a world where some individuals are viewed as not feeling or experiencing pain the way others do, I think emotionally and physically. And I think disproportionately, I think African Americans kind of fall in that category. The misunderstanding and misimaging, misrepresentation, I think, of our entire community and society, I think allows for many of the dastardly and unfortunate and adverse violent actions to occur, not only when you catch them on YouTube on a George Floyd situation, if you would like, but in everyday life. So we have a lot to do, I think, in our profession. One, I think educating ourselves and our colleagues who are not African American or ethnic minority to be very sensitive to and mindful of these issues and concerns. And I think also finding more structural ways to work through organizations like the AMA and the NMA and APA and other settings, organizations. I love the group at the very beginning, fraternities, sororities, and the like, all have, I think, an active role or a voice to play. I'll end by saying that this issue about feeling pain is also prominent for me as an African male. I've often thought that there's a misunderstanding that men in general, and even data argues that Black men are less likely to go and kind of discuss how we think or how we feel. We don't go to a psychiatrist. But I've been sharing with people for my entire career that my door for 20, 30 years, somebody's always knocking on my door, maybe not in a professional setting as a Black male, wanting to share or emote or cathartically discuss those concerns in that way, but in much more of a private setting, individuals I think actually have a story to tell as well. And I think that it's a group that's been hurting for a long time. And I think a lot of it came out here this last year, 2020. It started George Floyd, but in so many of those cases, I think that in the mental health field, we should be mindful of how we actually misunderstand and misappreciate, I think, persons who have minority who have been marginalized in this issue of how they experience pain, emotional, physical, for a long period of time. So work for us to do, I think, in this regard.
Well, I certainly appreciate the answer to that initial question. I will say that a lot of the follow-up questions that I was going to ask you already covered those, talking about the historical aspect, the generational trauma of African Americans, the decreased amount of mental health providers who are persons of color. I would like to say that I think more recently, I would say within the past 5 years, we have seen a lot of celebrities who have been very vocal about mental health issues and the need for receiving therapy. And so how do you feel like that influences our society and African Americans in general to receive mental health care?
Well, I think that's been fantastic because we all know in our world of influencers, it's important for folks to be the first and to come out and make it real. I remember Kevin Love, I think a lot of the NBA players, Taraji P. Henson. So I think it's very important for celebrities or any influencers to be open about their own struggles. I think it does. And I think even in hip hop, you know, a lot of folks are coming out and talking about these issues. And so it humanizes, I think, and makes people feel not so alone and afraid to talk about their own struggles. And I thought it was very important for our former First Lady to even talk about the struggles that she has had and feeling depressed during the COVID-19 pandemic. So I think that's been critical.
Yeah, I would agree strongly. And I think the other wonderful consequence of that kind of coming out has to do with that stigma issue. That when especially when young people see someone that they follow or they like their music or they enjoy them in media in some way. Charlemagne the God joined forces with Taraji P. Henson and Jennifer Lewis when Taraji P. Henson launched her foundation on suicide prevention. And it was wonderful to see the outpouring of attention that those three were able to garner in ways that the three of us could never arouse in the general public. I mean, it was wonderful. It was wonderful. You know, we are doing a great public service by when we go out, and especially the three of us together. But watching the audience at the launch of Taraji P. Henson's foundation and seeing that there were regular people, this was not just a celebrity audience, was just fantastic. And the fact that they talk about it publicly, they write about it. You know, we even got a shout out when Detroit won the NBA championship a few years ago before he became Meta World Peace, when Ron Artest thanked first his psychiatrist, not his mother, his psychiatrist. You know, that's when you know as a psychiatrist, we are starting to meet the standard when we get a shout out at a championship game.
Yeah, I'd argue that it's absolutely about stigma, and I think that throughout our history, very often someone else kind of has to make it right, and make a bridge, I think, to healthcare. I'm on his men tip today, if you will, but I know that in our community, very often, you know, men in general, you know, go to the doctor or get any kind of care when some woman of value to them tell them to do so. It may be their mother, it may be their spouse or the significant other or their daughter, what have you. And I think that we live in a world now where media-based images have become so prominent. Many of the media members that I think my colleagues have already mentioned, they have, you know, millions of followers on various forms of social media. So they very often come into people's homes and into their minds and their psyche very often, much more so than ever before. So they have a remarkably powerful opportunity to influence positive change. I think we all are very conscientious that unfortunately go the other way around. But when it does go in a positive way, I think for us is key. Final point I mentioned is that it's also very heartwarming because for so long, so many of the national images in psychiatry were negative. We all know the negative, the movies and, you know, the mistreatment and the, you know, very often the aspects of showing the psychiatric illness and patients in the most negative way and not normalizing it and making them normative, I think has really harmed us a great deal. And often persons are negative. The negative images are based on something they've actually heard that they haven't experienced. So this use of, I think, of positive celebrity in an effective way is a move in the right direction. We probably should be, I think, as Altha points out, much more demonstrative, figuring out a way to barter that in a more effective way going forward for many of our patients.
And Dr. Washington, if I could add a couple of things while we're on media and stigma, and I'd like to hear what Dr. Stewart and Dr. Bailey think about this if they've seen that. So first of all, in the media portrayal, I am a huge fan of This Is Us. And I don't know if anybody's seen that, but the African-American male character went through the issue of his first therapist being a white woman, if I remember correctly. I'm a big fan, I hope I remember. And then he didn't feel connected. And he ended up, there was a journey there, ended up getting connected to a group of folks who, are adopted, because one of his issues was adoption. But the other is finding an African-American therapist. I'm not sure it was a psychiatrist, but I thought that was a very good and realistic portrayal of that journey and the importance of finding a good fit. Now, we're not saying that if you are African-American, you have to, find an African-American therapist, but if that's your preference, and first of all, I wish we could fulfill that wish, but there are not enough of us, but still, I think it was real about that journey. And then the other thing is language. And one of the things that I've been doing is pointing out, I hear a lot of folks use the term, something is schizophrenic. They're not even talking about a person. Of course, we don't use that because that's not person-centered language. We use a person with schizophrenia. But anyway, they're talking about someone who changes their mind. That's sort of in the lay language. So that's just one example of the language that is used sometimes that can be very stigmatized. And so I would ask everyone in the audience to be mindful of language that they use around general conversations, let alone folks who definitely have mental disorders.
Dr. Harris, that is such an excellent point. We have to get away from this belief. And being a Southerner, I grew up hearing sticks and stones, and that whole line. Words matter. Everything from the example you gave about something being schizophrenic, as if that is the crack, the split, the something that conjures up this image. I'm locally on a campaign to stop using the word juvenile to describe children. You can say juvenile system, you can say juvenile reform, you can say a lot of stuff, but you cannot call a child a juvenile unless you get up every day and call your own child a juvenile. And I think we have to be intentional about that stuff. The other thing I think that the celebrity access gives us is debunking myths. There was for a long time a myth in the Black community that we didn't commit suicide. Well, tell that to Donny Hathaway, Phyllis Hyman, Don Cornelius, and a host of other people that we have lost to suicide. It happens. It's, mental illness is a brain disease. If someone has a and I'm sure there must be a few cardiologists and urologists and neurologists listening in today, you would not tell your patient, snap out of it. You would not tell them it's all in your head. Well, you might, but you wouldn't say it as the first line of defense. And we have got to, as Dr. Harris pointed out earlier, we've got to, within the medical community, develop that sense of value for psychiatry as a specialty of medicine. Some of us were in med school together, none of you young people, because I was way ahead of y'all. But there's some things we can do to debunk myths, to demystify what we as clinicians do. Our practice may not be procedurally based, but that ability to empathically connect in a therapeutic relationship with someone and get them to talk to you about what's really going on, and then formulate a treatment plan, do the regular, all of the review of systems and all of that stuff that real doctors do. Those are things that we value about our specialty. As much as we value the cardiologists for their procedural, prowess, and the urologists and the neurologists. Within medicine, we've got work to do. Within the general community, we've got work to do. And within the cohort of people who are already suffering greatly, as Dr. Bailey said, from the pain of mental illness or psychological distress or whatever you are comfortable calling it. There is pain there. It hurts to be depressed. Many of our medical colleagues send us patients that they can't figure out why they keep having pain, this somatization of this, they can't figure it out, and they send them to us, and we begin to drill down and peel that onion to find out what's going on underneath. So there's a lot of work still to be done, but I would agree with Dr. Harris on this one.
I'd add, I think that the point regarding how we communicate with other physician colleagues is an important one. I think much of my career, we've thought that we should speak to lay people about these issues, but literally I had an opportunity just yesterday. I had my students on Wednesday after the outpatient clinic, and we had a lecture and we discussed XYZ. And the point came up regarding changing patients on medications. And one of the students discussed that very often if a patient needed medicine X, you'd probably stop these meds and go to a different set, if you will. And to help to share with them that, as Altha just said, you wouldn't do that in non-psychiatric medicine. If I came for a consult and you on meds for high blood pressure and diabetes, but you also need some other treatments, I would maintain you on those treatments and try to add what I think is safe and beneficial and whatever my subspecialty is. It may be in a few areas other than psychiatry where the primary care doctor may think they have to stop the psychiatric medications, that they are the blame or the cause of the problem. So one of the messages that I think we have to really get across is the meds are not the problem. It is a brain illness, and the brain doesn't always work perfectly the way the heart, lung, and kidneys don't always work perfectly. And secondly, we probably shouldn't have excuses that, well, if you just didn't have a sociological issue, it wouldn't be the case. No, some of these issues in many regards are neurobiological, and they're going to happen anyway. But coming in and stopping the meds, if you're a primary care doctor or a non-psychiatry physician, sends a message that I think we want to move away from, that psychiatric medicines are the problem, or that they're not good enough or well enough to be maintained when you're adding treatments for, I think, the other considerations. Huge issues, subtle, but this happened just yesterday, and students are already picking up on it. At third-year med students points out that we very often repetitively keep promulgating messages that I think are antagonistic to the good practice of psychiatry.
Absolutely. So you guys brought up so many points in the last few minutes. Number one, that mental health is a part of physical health. We talk about medicine, all three of these physicians went to medical school, just like our cardiologists, our internal medicine doctors, our neurosurgeons. So they have the same level of training. And that is extremely important. So what they're doing is certainly providing a valuable aspect of medical care for their patient population. We've gotten a couple of questions within the chat and a couple of things we were going to talk about anyways. So the first thing that I do want to bring up, though, is we talked a little bit about it. We talked about increasing the number of underrepresented individuals in mental health to be mental health professionals. What do you all think about that? How can we go about recruiting our young Black men and women to go into the field of psychiatry?
Well, I'm a big believer in if you see it, you believe you can be it. And so between us, I think we spend an awful lot of time in front of people who could get interested if they were encouraged and might actually pursue psychiatry. So a part of this recruitment has to be being out there and talking about what psychiatry is, and more importantly, sometimes what it isn't. There are still medical students being advised not to go into psychiatry because they can be real doctors. And that is not an acceptable approach to the next, to furthering and advancing the cross section of medical specialties that we're going to need going forward through the 21st century. I also think this notion that creating a pipeline is the solution is only one part of the solution. Pipes leak all the time, and there are multiple places along the pipeline where people fall through the cracks, and we don't already get enough Black men into medicine. And then when we get them and can't get them directed safely into psychiatry, it further complicates. Rahn can't keep holding this up by himself. He needs help in the next generation or so. And I'm looking forward to retirement. So I'm certainly looking forward to those young ladies who introduced us and did a wonderful job, by the way. I'm so proud of my UT people. But I'm hoping that we come up with even more creative solutions to recruitment. in engaging young people earlier in the process. Girls ought to be involved in the sciences and not redirected from them. Boys ought to not be afraid to be considered nerds for liking science and getting involved in the psychological medical perspective. And we've got to demystify, we keep coming back to, we've got to demystify the practice of psychiatry so it's not some thing that we magically get into people's minds and make them do things. This is as much a science as it is the art of how we practice.
Well said. I jump in. I think that the issues regarding pipeline are huge for us. Almost every organization I'm in now is discussing pipeline issues, all of the medical organizations. And I think that the idea that we should be thinking earlier in the process of engagement is key. Doesn't start when you're taking the MCAT, when you're a third-year med student, trying to organic chemistry, what have you. We talk about the college level, we talk about the high school, we talk about the junior high school level, and even earlier. But I'm encouraged a little bit. In fact, I should mention I'm changing roles now. I am in Los Angeles now, but I'll become the chairman of psychiatry and assistant dean of diversity at LSU School of Medicine in New Orleans in about 30 days. And when I was interviewing the dean, and I'll call his name and give him some props. His name is Steve Nelson. He said what Altha Stewart just said, that one way to recruit, let alone retain and attract quality African male talent is to have African males in a position of authority and leadership in the medical school. And when he got there some years ago, they didn't have that. And you have to have some in that role of chair. So I'll give Steve some credit for that. And I think that we should be considering that across the full board in jobs that we have, in organizations. We're all in various organizations. I think medical and otherwise, I think we have to kind of press the lever where we have leverage to really encourage, I think, that exact consideration to happen. I've also recently been discussing with others that perhaps we should look in the areas of engineering, because so many young, outstanding African Americans in high school who've done well in STEM will pursue engineering, because there's scholarships for engineering very often supported by companies. But very often that may be a very good resource for us to begin to consider, not only persons who, like myself, started strictly as a pre-med student day one, but the engineering group may be an area for us to begin to think about, when we may have to find more persons who later on will go into medicine.
Ron, that is a great point. And congratulations. I was not aware of your new position. So congratulations, because I think representation and leadership matter. So that is critical. And I, like Dr. Stewart, absolutely believe that if you can see it, you can be it. Sometimes you just don't think you can do it. Now, I have two great academicians here. So one of the things, and it's been a while since I've been in the purely academic setting, but I'm hoping that when medical students rotate through psychiatry clerkships, that they get a very broad view of what psychiatry is. And I understand funding, and I get that, and the realistic issues around funding and budgeting. But I think for years ago, and maybe this has changed, the experience for medical students was perhaps in a locked unit. And clearly there's just a broad spectrum of those who have mental disorders, and there are those who have severe and persistent mental disorders who at one point may be dangerous to themselves or others and need to be in a unit that is secure. But the vast majority of folks that all of us see as psychiatrists, and let all of you out there know, in every other specialty, they may not be identified, but you are seeing a significant number of folks with anxiety disorders, with major depressive disorders, with actually bipolar and schizophrenia. So I'm hoping that our third year students get a broad view of what psychiatry is and does, particularly community psychiatry. And that may help. I don't know. That's my external outsider view.
Well, I just want to just tag along a little bit on that. I don't know what Ron's experience is going to be in New Orleans, but what we're seeing here is a crop of medical students who are not satisfied without that broad, more community experience. And if they have to do it through some volunteering and establishing programs and other things, if you know medical students, for example, I'll put in a little plug. If you know medical students who have an interest in psychiatry and may already be involved with Psych, which is the medical student group for students interested in psychiatry, have them apply to the APA for a medical student fellowship. Let them be around some psychiatrists, and particularly if they are students of color, because that's where they can see many more of us. And in each of these 3 organizations that we have been president of, that's where you're going to see clusters of Black people who practice psychiatry. And if that's what you're interested in, let's get them going, meeting us. I can't mentor everyone, all of us can't mentor everybody, but if we can expose them to enough people, they can latch on to somebody, decide they want to go to school. I'll also put in a plug, just in case my boss is on this webinar, that we are actively looking to recruit psychiatrists at the University of Tennessee. So anybody who wants to come to Memphis and be attached and affiliated with the University of Tennessee Health Science Center Department of Psychiatry, please drop me a line. We are actively engaged in recruiting. I'm sorry, Ron, but since it's my home territory, I'm gonna put the word out. And then I think the final thing is that as we go forward, I keep echoing what my colleagues here are saying, but as we go forward, the intentionality of what we do in identifying the workforce of the future should be our guide. We should be looking for places, whether it's engineering or whether it's people who may right now be in another specialty, but always wanted to do psychiatry. I know so many pediatricians who decided to come back, do psychiatry training, and became child psychiatrists. It is very rewarding work, and we need more.
Well, we are the area that when doctors go into an area and practice, train and practice, and at some point in mid-career they switch, the one that they switch to the most is psychiatry. I think you're right. Many people like psychiatry up front, but because the stigma didn't go into it initially. We should work to, I think, decrease the unfortunate negative hurdles that cause such.
Absolutely. So I am getting a lot of questions in the chat, and I got a lot of questions in the initial questions that were sent in for this webinar about the role of the church in mental health for the Black community. Like, what is their responsibility in assisting? So give us a little bit of insight on the role of the Black church in mental health care.
Significant.
I think it's huge. I think it's phenomenal. I think the role of Black church is, I'll just briefly say, I think it's our history has made it the signature really vector of information and comfort and safety and support for everything in Black communities, going back to times when there was the one place where you kind of had time off and you could kind of really be yourself, if you will, so to speak. But what I will say is that I think that I've been encouraged in more recent times that Black churches are embracing more of what we do. Early in my career, there was a health fair. You'd go and somebody could let you do a blood pressure screening or a diabetes screening. But now you can do a depression screening, and the pastor will support it and will come by and pat you on the back, says it's a good thing, and that kind of warrants, I think, positively sanctions individuals to want to go by it. A decrease of stigma in that regard as well. Strong support. I'm Catholic, and I think that piece has been a bit different. But I did grow up in that small part of the country between Houston and New Orleans, where there are Black Catholics. We're the only place in the country you'll find them, and clearly early in my life in that experience. There was antagonism that you could just feel. And I was fortunate that I think I had some other individuals who I think are a little bit more progressive minded about it. I think the Catholic Church is better in that regard now. But I think that we all struggle with this idea that many have thought historically that if you're okay with God, you could be okay with psychiatry, and there was a barrier between the two. That needs to, that stigma-based barrier needs to be eliminated.
Yeah. And I will go ahead, Patrice.
Go ahead, Dr. Stewart.
I was just going to add that I think in Memphis, for those in the audience who are in Memphis, we are really blessed that the majority of the church community, and as Bishop Young reminds me, especially the Black church community, has come to understand that we are aligned in our ultimate mission, which is to ease the pain and suffering of people who are under great duress psychologically. And there are a variety of places in town where churches actually lead the effort to assure that people get the psychological support and help that they need. The Healing Center being probably the primary one here in town, but also Mississippi Boulevard, First Baptist Broad. On any given Sunday, before the pandemic, you could go to many of the churches in Memphis and hear a sermon that, if you listen carefully, was all about being mentally well. All about it. There are pastors in town who can cite scripture around depression in the Old Testament. So, you know, we are fortunate in that regard. And I think, to our credit, the psychiatric community has been very supportive of making that alignment and partnership work well. I would invite people next Tuesday to a webinar that's being hosted by the Church Health Center, specifically on the role of the church in supporting the mental health of this community during the pandemic. Church Health Center's website has all the information. I will be a panelist talking about this. But here in town, through my center at UT, we have partnered for 5 years with various churches in helping children and families with mental illness and mental health issues. So we are fortunate. That doesn't happen everywhere, but we're fortunate here in Memphis.
I just said we have come a long way. I think about 25 years ago, I was in church and I heard the pastor say, you know, if you have God in your life, you don't need your psychiatrist. And I think Altha mentioned this a little bit earlier. We would never say, or I have never heard a pastor say, if you have God in your life, you don't need your cardiologist, you know, to treat your heart disease, or your endocrinologist to treat your diabetes. But that was 25 years ago. So certainly we have come a very long way. And I believe probably all three of us have been on multiple panels in the last several years, and a lot during COVID. But Altha, you said something, and this was said on a panel that I was on in some of the larger churches and maybe in the larger cities, but still there are probably some issues maybe in the smaller churches in the smaller towns, and thinking that, you know, if you have mental illness, it does mean that you are not praying hard enough. So we've come a long way, but we have to realize that it's still uneven. And I have to say, let's see, I think 2 or 3 years ago, you do lose a little bit of time in the pandemic, but at the last Congressional Black Caucus legislative weekend, I was on a panel with several ministers and church leaders. It was standing room only, and the topic was mental health in the faith community. Standing room only at the Congressional Black Caucus legislative weekend, and we were in a big ballroom, you know, not a tiny little room. So the good news is people are talking about it.
Absolutely. So all of these things are so important. One question that I did receive several times was, and we've also received it in the chat, is how can mental health professionals who are non-Black assist Black patients in their mental health care? Before I let you guys answer the question first, I do have some opinions of that on my own, even going back to general medical care. I think, first of all, it's very important that you, number one, acknowledge the history and acknowledge that there has been bias in the past surrounding medical care and psychiatric care for many generations. And I do think it's very important that you educate yourself about those things. There are a host of books that are out there and available. I think Medical Apartheid by Harriet Washington, The Health Gap, The Color of Law, all of those are excellent resources that you can use that will tell you a little bit about the history of medical care in this country and why African Americans tend to be a little leery of both medical care and psychiatric care.
I think that we all increasingly now are embracing what's a fairly new term towards many of us, is this idea of being anti-racist and having very proactive, very progressive, very forward-thinking actions that any and all might take, but especially persons who are not of the exact same culture, I'd say, or race or gender of any patient that might walk in and see me, for example, and see me as different. And that feeling of difference very often creates a barrier to communication that's essential, I think, in psychiatry. Same example, I think, for a non-Black psychiatrist or the like, they should be mindful of that. I think that part of the fear has been that historically the onus of responsibility is placed on the patient, in regard to the Black patient, to mend that gap or that divide of communication or culture, and that was certainly wrongful. I think we in healthcare should have always been responsible to make that patient feel heard, understood, that the culture was accepted. There's all kind of small things that can be done, I think, to make that work. The other thing I simply argue is I think that it's also key, I think, to get, somebody mentioned curbside consults, I think, in the chat, and I was going to come back to that. I believe in them. I think that we should all touch base with someone and kind of keep things on an even ledger. And perhaps that's myself and another individual who may be of a different race or age or gender, to make sure that we're all in many regards on the same page. That analogy, I think, is key for someone who's a Caucasian psychiatrist, for example, trying to take care of African American patients.
I would add that it is always tricky in the mental health arena, because the stigma, the anxiety, the concern, the history of racism, the fact that we're talking about psychological issues, which could be perceived as being weak or not being able to handle, or being perceived as somebody who can't handle things. And that's the last thing for many Black people that they want any white person to believe about them. And so it's kind of a tricky situation. But I think Ron hit on a couple of things that are worth amplifying, which have to do with the role of the therapist. It is not the patient's responsibility to make the therapist comfortable in an interracial situation. That's the first thing that has to be understood. Any therapist today, and I have said this publicly, so it will come as no surprise to people who've heard me talk. Any therapist today who has seen a Black patient who is not themselves Black and has not yet inquired as to their state of well-being in the presence of all that is going on that is seriously impacting the psychological well-being of Black people is practicing malpractice in my book. Because you cannot help a person unless you are willing to meet that person where they are. And so for me, the real test of whether a white therapist can help a Black patient is how willing they are to humble themselves in front of somebody who may have feel some kind of way about them, and how willing they are to say up front, I am not an expert in many of the things that may be part of what is troubling you. I am not going to ask you to teach me these things, but I do hope you will have a little patience and maybe even allow me a little grace if I stumble. But I want to help you, and I have basic skills that can be applied to everybody. And if you will work with me, I'm willing to work with you. I mean, I think the script that Dr. Ford did at the beginning about the referral, I think that is the perfect position for that therapist to take about making it okay to be in that cross-cultural environment. It is essential that people who go into therapy feel okay being there. You cannot do good work with somebody who is so anxious about what you're thinking about them and wondering about them and imagining about them and worrying about whether they're going to attack you, because all Black people attack white people, these days. You cannot do good work in that environment. And it is our responsibility as the professional to make that work. I feel very passionately about that. And I know there may be some disagreement in my profession about that approach, but I believe very strongly in that.
Well, I would just say we should, clip that, what Dr. Stewart just said about that script, about being honest, what you know and what you don't know, and you might stumble, but you also have an obligation to, as Dr. Washington said, read, get informed. You might get some peer help, although again, it's not enough of us Black psychiatrists around to educate, but I do appreciate and value when folks want to learn, although I have to say that at times it is a burden. But if a colleague wants to learn, maybe I'll say, well, read this, but I will say what Dr. Stewart just said should be, a TED Talk, or everyone, what you need to know if you really want and are concerned about being a non-Black person and you want to work with Black people. I think Dr. Stewart just capsulized it all in a nutshell there.
Absolutely. Okay, so in the interest of time, there's so much more to talk about. We're not even halfway through all of the questions, but I don't want to keep everyone on the line all night, because we certainly could talk all night with all of this expertise on our panel. So let's kind of take a shift, and I do want to talk about mental health in children. We hear a lot about the pandemic and children and how their lifestyles have changed significantly during the pandemic. So I did want you all to comment on that. And then we also got some questions specifically about depression and suicide screenings in children, and how parents and teachers and other healthcare professionals should address that with children, particularly in the age 10 to 14 group.
Well, Dr. Harris, you ought to lead off. You're the expert in this.
Well, we are seeing an increase, and this is across all age groups and across all demographics, of reported symptoms of anxiety and depression. Like we just said, increased substance use disorder. We have seen an increase in overdoses, overdose deaths. The jury is still out about suicides. At least, are they increased year over year? So we will need to collect that data and review that data post-pandemic. But clearly, we are seeing this, and we saw this increase in mental disorders pre-pandemic, right? We were seeing more and more children in my practice, more and more adolescents coming in with anxiety, and for a variety of reasons. Like we live in a very complicated world. In my opinion, and I'm older, but I believe that our young children are facing a lot more and having to deal with a lot more than I think previous generations had. When I made a mistake in high school or junior high school, a few people knew about it. But now when kids make a mistake, everyone knows about it. It's on social media. And sometimes kids do make mistakes. They say the wrong thing, put the wrong thing. By the way, I'm not talking about anything illegal, but on social media, and then everyone knows about it. So I think we are living in an era of a lot in social media, a lot of stimulus, and an era of anxiety, I'd like to say. And then recently we've had very divisive political rhetoric, and our democracy was attacked, and then the racial injustice, which is not new either, but has been enhanced, and the trauma of that. But again, that is building on the foundation of lives of microaggressions and trauma and weathering and all of those things. So yes, our adolescents are facing things, and I am seeing increased anxiety and mood disorder. We are also seeing, unfortunately, and I think I saw that in the chat, increase in suicides and suicide attempts of our young folks. And by the way, suicide and death by suicide is complex. I try real hard not to generalize. I just don't think we can. I know what the data shows, but the why it is difficult because it's always so complicated. But we know that it is. And we also know that children have less access to services. We've also talked about that. And so we really have to make sure that I think work with parents and families. There's this myth that if I ask about suicide, then my child might then attempt suicide. So it's just the opposite. We have to get folks comfortable with talking about it, listening, noticing when your children are not performing, not eating and sleeping, and have lost interest, and not participating in the regular activities, and be a good listener as a parent. And absolutely seek help. You can start with your pediatrician, a school counselor, someone you trust, but seek help early if you see these signs in your children.
I hate this because I'm gonna take advantage of being the home team here and being a proud member of the Bluff City Medical Society now. Here in town, we have the same challenges with providing services to children with mental health needs that are apparent across the country. Again, I have good news in that we have launched several programs to address some of those gaps in service, one of which I lead at the University of Tennessee. We call it the Center for Health and Justice Involved Youth. And it just so happens that next week, the entire week, is Children's Mental Health Awareness Week. And we have planned a host of activities to do just what Dr. Harris said, get the word out, let people know how to recognize some of these symptoms, to introduce them to some of the people who provide these resources that they may not know about or be concerned as to whether or not they can be trusted. As the director of the center, everything from TV and radio interviews here locally to webinars through the Church Health Center and through our partners at the Healing Center, we're going to go all out and go green for children's mental health next week. So everybody who has been calling me saying, don't you know someone that I can send my patients to, or my pediatric patients to, if you pass the word, we're going to have every resource we can get together in Memphis with us all of next week in a variety of ways. You can go on the UT website, find out all of these activities, where they're going to be held. Some of them will actually be in person. So that your families can actually bring kids out and meet with people, sign them up for programs. My entire team will be out there registering people for services. So now more than ever, we have an opportunity here, and people are paying attention in the state of Tennessee to the abysmal way that children's mental health services have been provided. And we're really, with the leadership of the folks at UT, we're really trying to make a difference in that. So I encourage everyone to go on the website, find out about these activities. And when you call and ask about that with me, I'm gonna try to have more resources lined up for the people, for my doctor colleagues, as well as the general public here in Memphis. I can't solve the problems of the nation, but I can work on Memphis, Tennessee.
I just add, I think that it definitely is Patrice's area being, I found today, trained in child and forensics, and it's Altha's grant, that their entire work there. But we experience the exact same problems here in Los Angeles. And I'm increasingly mindful after a fairly long history of adult work with and adolescent work on the issue of violence, and what I seem to be an uptick in just the sheer volume and gratuity, I think, of and the quality of the heightened amount of violence that I think children are exposed to. I run a hospital now that has 17 inpatient beds for children, and most of these units are, adolescents. We have 6 to 12, and we see 6, 7, 8-year-olds who've been exposed to not only the sexual violence, but other forms, I think, of just hand-on-hand violence, if you will, in a fashion that I think is that seems to be much worse than before. You mentioned one other person speaking earlier mentioned about a book that we just wrote on domestic violence, or IPV. I shared that all of the data, as Patrice mentioned, the anxiety numbers are up, but the home-based violence is up as well. So 2020 was a real bad year for our community and our society, and if more persons were at home and for longer periods of time, I think the tensions would flare, and a lot more, I think, children were exposed to the domestic violence that is settings, I think, in the home-based group. So I think that there's a lot to be said for us trying to find ways from a preventative strategy to address these concerns, and we give people tools to be mindful of such. Otherwise, I think our children suffer tremendously, especially children in settings where there's not an extended family provide better protection.
And if I could add a couple of things, Altha, you said, and because all of us are passionate about some things, but 2 things that I hear a lot in my patients, and I want to urge everyone, and I know no one on this call has ever done this, but number one, we need to let our children be children. Mm-hmm. I think that certainly no one wished this pandemic on our world, but I think people are thinking about priorities, and do we need to have scheduled every minute of every day? And of course, I would say this is probably mostly privileged children who, there's an activity for every second of every hour. Mm-hmm. And so here's an old fogey alert, but I hope that we go back and sort of re-prioritize and think about being less busy and spending time and that connection. Because I think that our children have been more and more on social media. I think all of you, we've probably seen adolescents who are at the same table texting one another. but I think now everyone appreciates the value of social connection. We are social creatures, and I'm hoping that we do more of that. And certainly from a broader perspective, we should be advocating the opportunity for everyone to do that, not just those who have privilege to make those connections. And so it's less scheduling and less pressure on our children, to be perfect and all those. There's enough external pressure. And I will say this, and I know sometimes people have good intentions when they say this, but do not tell young boys that they are the men of the family. I'm not associating that with anything. I'm just saying, don't do it. I don't think it's a good idea. I think we put a lot of, just one more pressure. These are children, not juveniles, as Dr. Stewart said, children. They are not the men of the family. And so we have to be mindful again of the language that we use. And I just wanted to put up a resource mentioned in my introduction, that I am the medical editor-in-chief of Everyday Health. And I took that position specifically, and they asked me to come on board and help them amplify Black health facts. They are interested in being a partner and an ally in getting the word out. It's definitely a consumer-facing website. And so I think we just need to make sure that we are referring everyone to websites that are credible. There's so much misinformation out there. So I just wanted to mention that as a resource. It's everydayhealth.com.
Okay, so let us make a transition now. So we've talked a little bit about children. Let's kind of transition over to adults. So when we talk about Black women, we know that we are often kind of taking care of everyone except for ourselves. So I do want to get some comments on the importance of self-care and the importance of Black women receiving appropriate mental health care. Can we talk a little bit about that, and then we'll transition over to the men?
Well, there are many avenues that this conversation could take. But we'll keep it general, because you're right, we don't want to spend the entire night talking. There are lots of reasons for Black women to pay more and better attention to their own self-care. We tend to be the caregivers for everyone else. We tend to put ourselves last. We tend to take on the role of protector, keeper, caregiver for everyone, often to the unfortunate outcome that our own health suffers drastically. That happens on the physical health as well as the mental health side. And one of the problems is that there was an author of a book whose name I'm not remembering, but she quoted herself in the book saying, "I ain't got time to be depressed. I got too much to do." And that is the unfortunate sort of life theme for many Black women. And there is a strong bit of reality in that, but there's an even stronger reason for us to do a better job of taking care of ourselves. If we're going to be pivotal in the lives of everyone else, we've got to be around. And we know, those three of us who are psychiatrists know, the statistics on depression, the statistics on other major mental health disorders are staggering for women. And the more we don't pay attention to that, the more affected we are, the more severe that affecting of our health and general well-being is, and the shorter lifespans we ultimately will have. We experience severe trauma in a variety of ways that I don't have to list, but those things add up. There is a cumulative accounting for all of these things that we say, well, I don't have time for that, and I don't have time to take care of that. That stuff adds up, and the body does keep score when it comes to that. Many of the women in the workforce, for example, are juggling lots of things. One of the things we learned in the remote working world of the COVID pandemic is that while everyone got settled into working from home, women got settled into working 3 jobs at home. Their regular job, their job of caregiver, homemaker, and everything else, and then the job of making sure that everybody was okay in the household. And then if you had outside responsibilities with an elderly relative or parent or something, that was a 4th thing. Nobody should have to juggle that many things and take care of themselves, which we tend not to do a good job of. The other thing I will just touch on is in the world of mental health, Black women especially are not often viewed from the standpoint of there may be a problem. The assumption is that something else is going on and you're just using this. People misunderstand and misperceive symptoms of major depression, for example. We often present with depression as Black women with a high level of anger and irritability, not with the I can't get out of bed and I don't feel like talking or moving around. And to not recognize that as a symptom of depression means that for many Black women, we're just carrying that label of angry Black woman when actually we're very depressed. And so there are some things I think that make it imperative that we begin to advocate and take care of our own health. But the healthcare community also has to recognize that sometimes we present a little different, sometimes we respond a little differently, and sometimes our issues are very different from those that people expect us to come in with. And that just all has to be part of the package of understanding how to, provide good care for us.
I will just quickly add, the reputation of the strong Black woman, which is, what I think Dr. Stewart described, can get us in trouble. And people feel guilty if they are not living up to that reputation, right? If they feel like they need help, oh no, I can't get help. I have to help others. I have to be strong. And so I think that's critical to recognize. And I tell everyone, not just women, but everyone, we should all give ourselves the grace and the space to not be okay. It is okay not to be okay. And we absolutely have to give ourselves the grace and the space to do so and seek help when we need it.
Yeah, I think it's Malcolm X that gets credit for having said the Black woman in America is the person that's been the most disrespected, the most hurt or harmed, the most misunderstood. Black men, of all the violence that I think our community and our society has brought toward Black men, have very, very often categorized Black men, understood them as being a threat and being someone that white male power structure should be afraid of, and should create an antagonism that's actually pretty prominent against them. But the misunderstanding of Black women has led to the mischaracterization of roles, the idea that, as Patrice said, Black women should be strong enough to handle it. I think the point of having to kind of work a job outside the home and another job inside the home is bad enough. And then on top of that, you have all of the societal ills and the family fiscal difficulties, if you will, that does lead to the 3 jobs, full-time roles that I think Altha mentioned, which is substantially problematic. I think that our society has tried to find ways to manage that. But one of our other struggles, especially now, I think is we miss generations. I mean, I think that there's too many settings where it's the grandparents that are given the attention or the responsibility for the parenting level roles that they should be involved in. Although I find myself sharing with my patients and friends and family and others, if you will, that we should expect parents to be parents. I love Bruce's point. We said children be children, a lot of them be so. I think it's a very good point. And I think that we all have to hold parents at some level of expectation. We have to help them, meet these roles, and if you will, if they have some difficulties based on their own parental upbringing. But our society was only, I think, be optimized and minimize the difficulties, I think, of mental health difficulties if parents are in their role correctly. And if grandparents, I'm a new grandparent, if grandparents are in their role correctly, it doesn't work well for us for society to determine that we should have a misrepresentation, I think, of the appropriate roles.
Okay, in the interest of time, let us make the transition to Black men. We have talked a little bit about Black men receiving mental health. And so I do want to make a shift and talk about, in this current climate, the role of policing, social injustices, police brutality on the mental health of Black men in particular, but Black people in general. And I know that's something we can talk about for 4 or 5 hours. I mean, we're going to go for the
chat. Somebody speaks about a part two. I think that they probably right about it. I'll try to give my third very, very briefly. I'll say a couple things. First and foremost, wow, but for video and YouTube and everybody having a camera, wouldn't we appreciate this world so much differently? And I think I mentioned Malcolm X earlier. Also, as a movie star, we still made the comment that racism hadn't really changed and we're shooting at Black people. But what has happened is we have video now. And it really, I think, increasingly is revolutionizing how we see and experience these ideas. I'm even sensitive to these so-called, quote unquote, Karen circumstances. The one in New York City and Central Park really gets our attention. White women being videoed and still overtly just making up a story and essentially, being disingenuous in an era now where you weaponize the police. You're not just doing that to, get this guy to get out your way. The police may show up and if the guy looks like me, large and African-American male, they may actually hurt or harm or kill you in a very, very, very vicious type way. So I think that there's no doubt the issue for Black men, remains problematic in our society, speak of misunderstanding us. But I also think that, we as a group are in some level doing better, finding ways to support one another. I mentioned earlier, this is regarding Black men really knocking on my door and asking for some degree of support. I'll share a personal story. Today, a friend called me, he's a dentist in Louisiana, putting together a big fishing trip. And XYZ alike, of 8, 9, 10 guys that I went to college with. And he had me to come with Bailey, you have to come. You're the psychiatrist in the group. And it's a bit jocular, a bit funny, but I was in by saying, so now I'm in a setting where people do appreciate that they've got a lot to get off their chests. Probably a year of difficulties, of responsibilities on one's shoulders, it's hard to handle, and not really having an outlet, any place to go. So whether it's somebody that you believe in or trust, as what I also said, a person is definitely a psychiatrist or not, there has to be some way to manage and leverage, I think, the supports that you have and decrease that pressure button. That's as important to Black men, I would argue, as other groups as well.
I don't even know what else to add to that. I recently heard a doctor from New York on the Doctor Radio show on Sirius, talking about his work in barbershops to spread the message, and that was pretty much the perspective that he shared, is that for men, especially for Black men, having a safe space where other Black men like him can get together and share this stuff before they even begin to go into a formal therapy kind of situation really does matter. And I think often we underestimate the importance of that and the value of that. Black men and women have somewhat different issues and approaches to dealing with these things. And we have to pay as much attention to the Black men who may benefit from therapy or may benefit from psychiatric treatment as we do everybody else. And I think we are often put off by the fact that they probably aren't going to do it anyway, and they don't open up to anybody, and they don't like talking, and you can't get him to say nothing. And we really can't give up on Black men and letting get the help that they need.
And we have to talk about trauma, specifically, we have to ask about trauma. Certainly the trauma from racial injustice and police injustice. And I'm talking about men here, also the trauma from any abuse. We cannot make assumptions about who is most likely to have been the victim of abuse. So I know there's been a lot of conversation about trauma-informed care. It's almost become, it's always something du jour, right? We sort of find the thing of the moment, but we have to really get serious and make sure our systems are trauma informed. And one thing tonight, we've been talking about mental health, and we have to make sure that and advocate for all of the systems, right? The health system, yes, but also the justice system, also transportation, city planning, zoning, all of those systems contribute, policies, racism, right? And I don't, have we used that word tonight? We need to make sure that we are talking about, again, CDC, my organization, all of our organizations, the AMA, recognizing that racism is a public health issue and public health threat. And we have to make sure we continue to have people have those conversations. We cannot shy away from talking about racism and structural racism, no matter how difficult some people may say it is for them. Well, we got to have these conversations.
Let the church say amen.
Amen. I absolutely agree. Before we close out, again, in the interest of time, this has already gone a little bit longer than we had planned, but again, so much information. Let us talk specifically about access to mental health services. We already know that there is a shortage of mental health providers in general, in particular in mental health providers of color. Can we talk a little bit about the availability of virtual mental health services and how people may go about accessing that a little bit?
Yes, positive. I mean, the reality is, even before 2020 and COVID-19 pandemic, about up to a third of psychiatrists saw patients over using a virtual medium. So I think that individuals certainly should ask. It certainly can be done. I think in addition, of late, we just have newer and better technology. I mean, you can do it on your cell phone now, from your car. You don't even have to be at your office with a camera and that type of business. So I think that patients should be encouraged, people should be encouraged to do so. We think a psychiatrist is actually going to help us. There may have been a cohort of individuals who wouldn't go to the doctor because of paranoia or fear or anxiety. Is there nothing for just the transportation challenges that I think Patrice just mentioned, having to get there and get off work and that type of business, that I think virtual opportunities will help with. As an expert here in the Southern California area where I am, Peter Yola is his name, who speaks about this at a weekly conference that I attend, and he's kind of pointed out how it's really revolutionized the offering of care for persons who historically wouldn't go for care for all of those stigma-based, barrier-oriented reasons and fiscal reasons. And we're seeing, I think, that's being opened up pretty substantially. I end by saying that, much of my career I've really wanted to work in a setting like where I am right now, where you can come if you have no money. So I'm in the county hospital system in Los Angeles, and we finally begun to make money, or lack thereof, to decrease its essentiality in getting substantive psychiatric care, inpatient and outpatient, I think as Patrice mentioned earlier. So clearly, I think that we should encourage persons to go for care, not wait until it's the end resort, or they should go early on, be more progressive and preventative. We also should make persons aware that they have some opportunity to ask for the level of engagement that would be best for them, including telemedicine or telepsychiatry.
Absolutely. So we are coming to a close of this program. Certainly, I have been just really blown away by all of the expertise on this panel. Thank you all so much, Dr. Bailey, Dr. Stewart, and Dr. Harris. This has been very enlightening. I know you all can see the comments in the chat. I've gotten so many text messages on both phones, emails, direct messages in the chat. People want part 2, 3, 4, and 5. And I realized that everyone is so busy. I was so excited when I was able to get the 3 of you all in the same virtual space at the same time. So I am immensely grateful for that. The Bluff City Medical Society is immensely grateful for that. So you all know, we will have a recording of this that will be available on the Bluff City Medical Society website, and it will remain in place on the Bluff City Medical Society Facebook page. So certainly you can access that resource at any time. We do have some mental health resources that were put in place by the residents for adult and pediatrics. They are available on the Bluff City Medical Society website under For Patients and Mental Health Resources. Again, if you have any questions, concerns, or feedback, please feel free to give us some comments. You will get a Zoom email after this event. Please give us feedback. We certainly look forward to that. I apologize for not being able to answer all the questions that were sent in. We just simply don't have enough time because certainly we have all of the expertise here right now. So thank you all for joining us, and everyone have a great evening.
Thank you. This was a wonderful panel. Thank you.
Great job, Dr. Washington.
Thank you.
And as always, the two best psychiatrists in the country, Doctors Altha Stewart and the good doctor, Patrice Harris. Good to see you.
Good to be with my friends.
I see a TV show or something.
I'm thinking we need to do this more.
If
we need to do this
here is a publicist or has output from local media or national media resources, please reach out to me. We can certainly make this happen into a television series about Black mental health because it's so important.
Well, I think you've got the right three.
Absolutely.
And we'll talk, Dr. Washington. We'll talk.
We will.
I know how to find them.
The only one that we could do other than virtual, we could have it on site, be in Memphis. I had a good barbecue in Memphis.
Yeah, we could do that. We could do that we could do it a few shows over a weekend. We could do barbecue. We could go to church, we could hang.
By the way, Dr. Stewart and Dr. Bailey, I just recommended you all for a program in Atlanta, so you'll probably be hearing from some folks here in Atlanta. So.
And both of you will be invited to New Orleans for grand rounds. Come down, probably 2022, and we have some good food down there too.
Yes, you do. Yes, you do. And then we'll all be together this weekend, I guess, at the APA.
That's right, virtually. Yes.
Yeah. Laptop.
Yeah.
Yeah. All right. See you guys.
All right. Good night, everybody. It was great, Dr. Washington.
Yes. Thank you, Dr. Washington.
Those trips. So make
sure
yes.
Me, please.
You're an honorary psychiatrist now.
That's right. That's right.
One of us.
Good night, everyone.
You're the
Thank you. Good night. Bye-bye.